Welcome, welcome, everyone. Thank you so much for coming out tonight. We're really excited to have Dr. Joseph Jarvis here, all the way from Utah. My name is Rebecca Cerise, and I'm part of a really amazing group called Healthcare for All Y'all. We are based out of Orange County, North Carolina, and we are passionate advocates for what we call improved Medicare for all. We think it's really the only solution for covering everybody and controlling costs. So we try to educate folks, to empower people to advocate for this, to talk to our elected officials or people that are running for office, because only by electing people that support this will we move forward towards it. Along those lines, we have some educational materials. We actually put together a candidate packet to give to House candidates that explains the bill that's in the House right now, H.R. 676. And we're looking for people to give it to their either person running in their district or their congressperson. So if you're interested, you can pick up a copy in that back table over there. We also have, or sign up and we can send it to you electronically. There's a sign-up sheet. We also do a 5-minute action on Facebook, so you can like our Facebook page, Healthcare for All Y'all. Every Thursday we send out an article or a video about some aspect of healthcare, again, to inform and empower. And we also have a roadshow, a slideshow roadshow that we're happy to bring to your group if you would like to learn more about it. And then last but not least, we have a 2-page, a double-sided fact sheet on Improved Medicare for All. We sort of look at it as a Improved Medicare for All 101. So I wanted to start off asking a question. How many people here, show of hands, have had to argue with their insurance company about covering something for themselves? Yes. How many people think they're getting a good value for what they're paying for insurance? Huh? Medicare. There you go. Yeah, so Medicare, a good deal, exactly. And imagine what can happen if it's improved. So before I bring up Dr. Jarvis, and by the way, as you can see, his book, which just came out in September, is available for purchase. On the back, it's called The Purple World, The Healing, the Harm in American Healthcare. It's a wonderful book. It's filled with really incredible anecdotes about his time in Las Vegas and other places, trying to actually do good public health and the things that he ran into. So before I bring him up, I just want to sort of lay out a few things about our healthcare system to sort of introduce you to our issue. So the current healthcare system, like I said, is bad for our country. Despite our vast wealth, and we spend far more than other countries, our healthcare has failed. The health outcomes aren't that great, and millions of people face financial ruin from medical expenses, and our costs keep rising, which I'm sure you all have experienced. So it makes it impossible for individuals and businesses to keep up. It's bad for the health and personal finances of Americans. It's bad for American business. You can see Charlie Munger, Vice Chairman of Berkshire Hathaway. He says, our cockamamie system gives our companies a big disadvantage in competing with other manufacturers. And in fact, Amazon, Berkshire Hathaway, JP Morgan, they're all looking at getting into the healthcare business because the system as it exists now is such a burden on them. So it's a big competitive disadvantage to our country. And it's also bad for our productivity and our economic stability and our security in terms of public health risks. So like I said, we have the most expensive system in the developed world. We spend almost more than double what other countries spend, just about $10,000 per person, and some per capita. More recent numbers have us above 10,000. So why is that? Well, we have a privatization of our system that doesn't really exist in other countries, and it leads to profit motives, really creating high costs. We used to hear, oh, well, we don't want the government between us and our doctor. Well, right now we have a often for-profit middleman that is in between us and our doctor that has a perverse incentive to deny us care because for profit. And we are paying them to do that. And they don't have, most of them don't have medical degrees, but yet they are superseding what your medical provider is saying. And so you're no longer getting to make your own decisions. It's being made by this other private company. So they redirect billions of their dollars to shareholders, executive salaries, bonuses, advertising, lobbying, campaign contributions, and the lobbying and the campaign contributions is sort of how we are where we are. So we wanted to sort of show you sort of the understanding of the critical flaws. It's a bureaucratic mess. Nobody likes inefficiency, and our system is incredibly inefficient. We have a very confusing multi-payer system. We have public services, private insurers. We have redundancies in administrative work, and it's a big mess. We have insane administrative costs on the provider side and insane administrative costs on the insurance side. I mean, in some cases, we have more administrators than actual providers in certain places. It's also, so that money is all going towards paperwork instead of care, which is not good for anyone. When I found this out, it sort of drove me a little crazy. So private insurers are profiting off of our public dollars. So it's not just us paying them, our premiums. This is our public money that we pay into the government. So the for-profit insurers are managing more and more of Medicare and Medicaid services. In fact, in 2019, North Carolina is shifting to a managed care organization system of dealing with Medicaid. So we are basically privatizing Medicaid in our state. So that will be our public dollars going towards private companies, some of them are for profit, to manage Medicaid. Over a period of only 6 years, private insurers more than doubled their revenue from these public programs, to the point where now 59% of their total revenue comes from Medicare and Medicaid. So 59% of their total revenue, of the top 5 for-profit insurers, are now making money off of our public programs and our public money. And note, this does not include the ACA subsidies or health insurance that is state and federal government employees. And like we mentioned, this is 2016. The median earning of a full-time wage and salary worker in 2016 was $43,264. And you can see the top insurance CEOs were making just a little bit more than that. Again, that's our money going towards profits, CEO salaries, instead of towards care, which is, sort of where we want it to go. It's just a waste, it's inefficient, it's a really ridiculous way to do healthcare. So on top of all that, we don't even cover all our people. We have about 30 million people who are uninsured and about 41 million and counting who are underinsured. And I believe more people don't know that they're underinsured because our insurance plans are so confusing that people don't even know what they're covered for until they need it. In fact, 24% of people with employer plans and 44% with individual or marketplace plans were underinsured in 2016. So underinsured basically means you're paying for insurance, but you still can't get the care that you need because of out-of-pocket costs are too expensive. Because obviously we're not just paying premiums, then we're paying co-pays, deductibles, all these out-of-pocket costs. And as you see, interesting, so the light blue are people that have good insurance all year, dark blue are underinsured, and the orange is people that don't have insurance. And I think the interesting thing about this is how similar, and in some cases more, the people who are underinsured are having similar issues to the people who have no insurance at all in terms of paying for their bills. And of course, not being able to pay your bills or not being able to get the care that you need leads you to getting sicker and then ending up in emergency rooms, which guess who pays for if they can't pay? Us! So again, inefficiency, we're just doing it all wrong. We're paying the most money in the most inefficient way. So certainly if we are spending the most, and we're not covering all our people, but we have to at least have good outcomes. We don't. We are bottom of the 11 countries that were studied by the Commonwealth Fund in overall system performance. So it's like 11 different things that they look at. We also have the worst maternal death rate in the developed world. We have lower life expectancies than almost every other developed country. And we really have very bad infant mortality. So we're not doing so hot. Well, that's sort of my opening to sort of set the situation up. And now I'm going to introduce our esteemed speaker, Dr. Joseph Jarvis, Q. Jarvis. So Dr. Jarvis received his medical and public health training at the University of Utah School of Medicine and has been a family medicine physician in Salt Lake City and Reno. He was a faculty member at the University of Utah, University of Nevada, and Colorado Health Science University, and he was a public health physician at OSHA and the Colorado Department of Health, and he was the Nevada State Health Officer, which is what I was telling you. He has all those great stories in his book about his time as the Nevada State Health Officer, some of which you will not believe. For the past 2 decades, Dr. Jarvis has been a consulting public health physician and has sought state office in Utah as a Republican candidate, which is our way of saying this is not a partisan issue, this is a human issue. We just want better care for all our people in a way that we can also control costs. Dr. Jarvis?
Thank you. It's really good to be with you. The bare facts that you've just heard recited would lead anyone to believe that something's wrong with the American healthcare system. We have very high costs, as she's very clearly outlined, and very poor outcomes. And the question I have for you to ponder, which I hope to elucidate as I speak, is why would that be the case? How is it possible that we have such high healthcare costs, we pay so much, and we get so little for it? How does it work like that? If we are to believe what we're told by our leaders, I shouldn't call them leaders, the people that we elect who are supposed to be our servants, our public servants, then we have high costs because we have the best system in the world. That's what they tell us. There are many, many videos that I could show you of members of Congress who stand before the camera and say, well, it just costs more to have the best healthcare system in the world. That's the continual refrain. The problem is that it isn't. It is the best in one way and the worst in terms of other ways. The way it's the best is it's the most profitable healthcare system in the world. That's clearly the case. It is, as the last slide that you just saw indicates, it's not the best in terms of patient care. Before I show you my first slide, let me give acknowledgement to this gentleman, Dr. Brent James, a friend of mine in Salt Lake City, who used to work for Intermountain Healthcare, which is the major hospital system in Utah. It's a nonprofit system, and his job was quality improvement. He led Intermountain Healthcare towards a higher quality system, and I'll show you some information later that indicates that he succeeded in many ways. And every time you see a slide that has a blue field at the top and a black field at the bottom, I borrowed it from him with his permission. So here's more Commonwealth data. You've already seen some data from the Commonwealth Fund that were already shown to you. This statistic, the mortality amenable to healthcare statistic, I think is the best single statistic for health system function. How well does a health system actually prevent the deaths that healthcare can actually do something about? That's what amenable mortality refers to. Not every death would have been somehow prevented or avoided with good health care because of a variety of factors, age being the most important one. So in doing these studies, they start by looking only at mortality younger than age 75, just to make sure that they don't punish a system because it happens to have a nation of older citizens. So this is amenable mortality. I want you to notice that virtually all of the first world or the developed world is indicated by name along the bottom of the slide. On the very far right, your far right is the United States, 2 bars. The white bar being for a study done of amenable mortality at the end of the last century, and the red bar being about a decade later, early in this century. The United States was not the worst for amenable mortality at the last of of the previous century. It was close to the worst, but not the worst. However, over the intervening decade, all nations improved in this performance measure, including our country, but our country improved less quickly. It made a smaller amount of improvement than the rest of the developed world, and so we ended up being the worst for amenable mortality at the end of that decade of study. Now, some people would argue, well, that was before we did health system reform, which is now known as the Affordable Care Act or Obamacare. So clearly we've improved, right? We've changed. This is the same set of data, fewer countries, but essentially the same countries. Looked at, again, from the middle of the previous decade up into this decade after implementation of the Affordable Care Act. And what you can see is we still remain lagging behind the rest of the developed world. In our nation, you're more likely to die from a cause that healthcare could actually do something about than the citizens of any nation in the developed world. We spend so much more and we get so much less. Again, why is that? What is it that we're doing wrong that actually makes that inevitable? The Patient Protection and Affordable Care Act was supposed to help us with all this. And its focus is perhaps one of the reasons why we need to kind of relook at how we approach health system reform. Here are the main points of the Affordable Care Act, or Obamacare. You might remember what was called the individual mandate, meaning people had to buy insurance, they had to buy a product. One of the things I like to point out to people is that by itself indicates we don't have a market in healthcare because we had a law that said you had to buy a product. That's not a market. Right? People are forced to invest in something that maybe they wouldn't have otherwise done so. Those who absolutely positively were not going to be able to afford that product, who had income at 133% of the federal poverty line, that's what the FPL means, at the second line, they got into an expanded public program in some states through this act. And that expanded public program is Medicaid. Medicaid is a shared state and federal health program. It's an expansion of coverage for a certain group of people, mostly those who are poor. Just like Medicare is a federal, not shared with the state, program for those who are older than 65. Let me ask you, why would it be the case that we have special governmental programs for people who are poor and those who are older than 65? Well, it gets back to the fact that profitability is what health insurers are all about, and you can't make money providing insurance to people who are old or people who are poor. Most of the poor, a good number of the poor, are poor because they're unwell. They've been injured or they've been sick, and therefore they haven't been able to work, and therefore they're less well off. That's how you end up in that category. Most Americans want to work, and whenever given the opportunity with the ability to do so, they do work. But those who have somehow fallen on ill times or had a family illness or injury can't do that. That program was expanded under Obamacare in order to try to include more people in it, and actually most of the expansion of coverage under Obamacare occurred through Medicaid, even though almost half the states refused to do the expansion, such as my state, Utah, did not do that. The exchanges were where you were supposed to be able, in a marketplace, buy the product. States sometimes provided them these exchanges, which were online, and where a state refused to comply with the federal guidance for these, the federal government provided an online exchange. That's how it was expanded. And you'll all remember the very difficult unveiling of the online exchanges and how hard that was. Many people who thought they were getting coverage ended up not having it. Well, it was awkward, it was difficult. I'm sure most of those things have been improved since then. Some people who had higher than 133% of the federal poverty line income, but lower than 400% of federal poverty, were given a subsidy when they bought on the exchange. When they bought an individual policy or a family policy on the exchange, they got a subsidy. Now, that came with the caveat, perhaps some of you were among those who bought on the online, and you did that, you had told You had to fill in your income and a variety of other things about you. Lots of information had to be given to the online site. And then you were told at the end, if in fact some of this is in error or you make more than you think you will and you don't really qualify for the subsidy, we'll come after you and there'll be a penalty for that after the fact. I've spoken with many people who chose, because of the uncertainty of that, who chose simply not to buy a policy because they were afraid. They thought I would rather pay the penalty that I know, which was violating the individual mandate, that penalty, than pay a possible penalty that could be a lot bigger later. So those are the premium subsidies. This was the way coverage was to be expanded to more and more Americans. And in exchange for that, now after all, this is millions of people whose business is being forced from them to be given to the insurers. This is a gift to the health insurance industry, a huge gift. And we were supposed to get something in exchange for that. We were supposed to get guaranteed issue and modified community rating. Guaranteed issue means that no matter what background health issues you have, you can get a policy. That's still being fought over now among members of Congress and various states who are suing or not suing, trying to protect this act from various actions about it. Okay, that's guaranteed issue. That's a gift we're supposed to get. And modified community rating means rather than being assessed a fee or a premium for your insurance based on your past health experience, community rating is everybody pays the same premium. That's actually how health insurance was invented. Back in the Depression, the first health insurance policy, the first Blue Cross policy, was sold to teachers in Houston, Texas. And they all paid the same amount, and in exchange for that, they got 21 days, up to 21 days of hospitalization in the premium year. They all paid the same rate. Later, after World War II, the health insurers began transforming from nonprofit to for-profit, and they figured out pretty quickly that some people used more health care than others. So they started trying to differentiate between their beneficiaries and charging a higher premium, doing away with community rating, and instead doing what's called experience rating. That's the common format today. And modified community rating isn't actually community rating. It's actually experience rating, right? It's modified experience rating. They try to take some of the extreme levels out of it, but it's still, if you have a history, they're still going to charge you more for it. Now, there were a couple of other things, like young adults were supposed to be able to be on their parents' policy for a few more years that played out. That's the Patient Protection and Affordable Care Act. Where in there do you see something that suggests that it's going to improve the quality of the experience for you? Now, there were some things, it was 2,000 pages after all, and I've only given you a few lines. There were some things that were alleged to be about quality improvement, but this is a traditional health policy approach for Americans. We have over 50 years recurrently gone back to the issue of health care, and we always end up doing the same thing, which is expanding coverage. That's what these are about. It's not about the actual problem of how come it costs so much, and doggone it, why is the quality so poor compared to, why do we have the poorer outcomes? This was actually understood by this man before Obamacare was passed. He was in the White House as an advisor, a physician advisor to the Obama White House before the start of the process that ended up with the Patient Protection and Affordable Care Act, which is, of course, not about patient protection, and it's not affordable either. But, okay, we'll leave that alone. Dr. Emanuel, whose brother Ram became the mayor of Chicago, advised the nation through an article in the Journal of the American Medical Association in 2008 that we need to stop thinking of coverage as the real issue about health reform. That isn't the issue. He said instead the issue is cost, because it's so enormous in the United States. You saw the slide, $10,000 per person per year. Let's put that in perspective. The Russian economy, that's the entire per capita GDP for Russia. $10,000 per person, that's what the entire GDP is. In the United States, that's 20% of the GDP. So we have a much wealthier nation than Russia does. But $10,000, that's twice what the average is for the rest of the first world. That's a lot of money. Where is it going if we're not getting something for it? That's why he said cost. So let's look at cost. As I mentioned, you've already seen that slide that shows you per person cost. This is a slide that transforms it, instead of per person, into the percentage of the gross domestic product. Over many years, there is a group of countries, most of which are from Europe. There's also Canada and Japan in there, so a little bit of Asia, a little bit of North America. And the United States, you can see our line is well above everybody else's. Along here is the percentage of the gross domestic product, and over here is the years. Back here when it starts in 1960, when I was a little boy, we were really no different from the rest of the developed world in terms of the percentage of our gross domestic product spent on health care. By the time I became the state health officer in Nevada in the mid-'80s, we'd started to differentiate and grow higher. I remember attending a meeting for the Nevada State Medical Association where a health economist came in with alarm, pointed to that first burst that pushed us up above the average for the rest of the developed world. And that health economist said, this is a problem. We can't allow this to go on indefinitely. Now, think about that for a second. Why would that be such a problem? One of the doctors in the audience said, but healthcare's a good thing. Isn't it good to spend more on a good thing? Ask yourself the question, why is it wrong for us to go deviating further and further up there? The answer is because this is a zero-sum game. Every percentage of the gross domestic product that's devoted to healthcare is not devoted to something else. You cannot have 100% of the gross domestic product devoted to healthcare, right? Because we still need to feed ourselves, we need to educate our children, we need roads, we need railroads, we need all kinds of other things. There is a limit to how far this can go. What is that limit? Where is the brick wall where we're going to hit it and everything else is going to fall apart? Some people suggested we've already passed that. I don't know how many of you are old enough to remember the first Bush administration. That first Bush administration, that President Bush, claimed that he was going to become the first education president of the United States. And he held a big summit about education, and they came up with a big blue ribbon plan for improving education in the United States. I don't know if you follow this, and I don't assiduously, so I don't know the details, but we have not kept ahead of the developed world in primary and secondary education. We're not very good at that. Our children are lagging behind in many measures, the children in other nations in the developed world. Why? In part because we didn't follow that blueprint that the first Bush administration produced. One of the major consulting firms in the United States, McKinsey & Company, recently said, if we had followed that, if we had educated our children back then to that level, those children would now be in the workforce. And our gross domestic product with that more educated, more trained, better off workforce would be $3 trillion a year bigger than it is today. Now, we do have the world's biggest gross domestic product. We are the biggest economy in the world. And if we're at 15 trillion or so in gross domestic product, if we had that extra 3 trillion at 18 trillion, think what that would mean. There would be lots more taxes, for instance, to support public programs. There'd be a lot more wealth that we would be sharing one with another. Incomes would be higher. $3 trillion is a lot of money. It gets to be real money, as they say, once it gets past $1 billion in Congress. So some people have said, why is it that we haven't done that investment in education? Well, the biggest competitor for education dollars, and those are public dollars, that's what goes to education, the biggest competitor is healthcare dollars. If you go to a state legislature and watch them argue about the budget, you'll find them trying to figure out how they're going to pay for that Medicaid, the portion the state owes for that shared state and federal program called Medicaid. Where are they going to get those dollars? And those are coming directly out of the same general fund that actually would also fund education. So that's part of the problem. But let me give you a more definitive answer about where the brick wall is. The former governor of Utah, Michael Leavitt, who went and served in the second Bush administration, first as the director of EPA and later as the Secretary of Health and Human Services, has recently said that there is no place on the international leaderboard for a nation that spends 25% GDP on healthcare. Let me repeat that. There is no place on the international leaderboard for a nation that spends 25% of GDP on healthcare. In his opinion, we are heading to the brick wall. We're already, you can see where we were at about almost 10 years ago. That's the end of the line up there, the United States. That's 18% GDP. In the 10 years since, we've jumped up to almost 20%. So that would put us at the very top corner of the slide. We're continuing to go very, very high up, very fast up, okay? We're at 20%. We're rapidly going, that's every decade we're going up another 2%. So how soon will we be at 25% and therefore no longer able to carry a burden of being an international leader as a nation? This problem, this GDP problem, is actually placing us in the difficulty of where are we going to be a first world nation or a second world nation? That's the question. If we keep making the mistake of allowing that to go up while the other nations have learned how to keep it more balanced, that's where we're headed. It'll be the failure of our country. Now, there's a gap between us and them. That gap, if you calculate it out in US dollar terms, that gap is worth $1 trillion. I call that gap waste. Okay? Why do I call it waste? $1 trillion of waste. Why is it waste? Because that's spending without increasing the outcomes. I've already told you that the outcomes are poorer here. We have the worst amenable mortality in the world, in the developed world. We're spending $1 trillion more than the rest of the first world, at least in our terms, based on our economy. That's waste, right? Would you agree with me that that's a wasteful situation? Somehow we're throwing $1 trillion away. We're getting at, I think, what the real reason is why we can stand here and look at our system and say it's highly costly and poor quality. I'm going to give you a story, one of my stories from Nevada, and it involves my daughter. My daughter, Caitlin, who is actually the reason I'm here in North Carolina. My daughter, Caitlin, was born in Nevada. We were expecting her when we moved from Washington, D.C. to Nevada those 2 or 3 years ago. And I had just finished a few years before that my training in Salt Lake City, and I was still on the health plan that I had for my family from Salt Lake City when we moved to Nevada. And as I got acquainted, I was starting my time as the state health official, the public health leader for Nevada. I started meeting people in the medical community. There was an evening when I had been invited to bring my wife, and we were having dinner with the Pediatric Society in Reno. And several of the pediatricians went out of their way to pull me aside, having noticed that my wife was clearly expecting a baby, and said, look, you may not understand this, but if there are any problems with this pregnancy, you need to go back to Salt Lake to deliver that baby, because we have awful, awful neonatal intensive care here. Do not allow a sick baby to be born here in Reno. Take that baby somewhere else. Can you believe that? I mean, that is an awful thing for people to be saying. And of course, it really got my attention as the state health official, thinking, you know, what am I going to do about this awful situation that's here? No problems with the pregnancy. We delivered in Reno. She was healthy and remains that way. It was great. And then we submitted the bills, of course, to the insurer, who was a Utah insurer. And it turned out that the bill for her labor, delivery, and newborn charges was twice as much as the bill that had been true for our child who was just older than Caitlin, delivered in Utah in Salt Lake City, 2 times as much. And the insurer in Salt Lake didn't want to pay twice as much for that. That was the going rate in Nevada, but it was half that much in Salt Lake City. Now I have a question for you. How can it be the case that care that's manifestly poor, because that's what the medical community said it was, care that's manifestly not as good is twice as expensive? How can that be true? Why is that true? That shouldn't be true, right? Worse care should cost less. Okay, right? I'll go further than that. At the time that I started serving as the Nevada State Health Official, Nevada had the highest per bed per day hospital costs in the nation. This had been a matter of great concern to the legislature. And I began to really puzzle about that, because I was back in Utah. We had just gone through the artificial heart implantation. The very first artificial heart implantation occurred while I was a resident in Salt Lake City. Kind of in a side note, it's called the Jarvis heart, right? And I'm Dr. Jarvis, right? So I would walk into rooms, I'm an intern. I would walk into a room to see a patient and they would go, quiet. And they would say, wow, we have the Dr. Jarvis. I go, no, wait a second. It's Jarvis heart, I'm Dr. Jarvis. It's a different guy, okay? It's not me. So we had artificial heart implantation, but that was because we had great open heart surgery there. We had a burn unit. We had trauma care that was highly organized and regionalized in the way it should be delivered. In Utah, we had neonatal care that was highly recognized. In fact, when I was on the OB team, I would often be put on a plane and sent somewhere in the Intermountain West to pick up a mother in trouble and bring her to Salt Lake where we could deliver the baby where there was better care. That often happened. None of that was true in Nevada. Not a single one of those things was true. There was a little open heart surgery, not much. Trauma centers, regionalized trauma care didn't exist. Burn units didn't exist. Neonatal care, I've already described for you. None of it was true, and yet hospital costs were twice as high in Nevada. How can that be? Waste is how it can be, and I'm going to get into the details of what waste is, what I mean by that. Waste is what drives that. Now, you may hear the term bending the cost curve. I don't know, that's a pretty sophisticated parlance among health policy analysts, and this is what the jargon that they talk about. They say, we've got to bend the cost curve. This is what they mean. When they're referring to bending the cost curve, they're trying to say, somehow we've got to stop this upward trend in GDP percentage on that curve, and it's got to be bent back down towards the rest of the developed world. If not, we're going to hit that barrier, and our nation will fall apart. Impossible things don't happen. You can't be a nation that devotes too much money to healthcare and ignores education and all these other things. The infrastructure will fall apart. You become something other than you wish you were. Is this making sense? This is our cost problem. This is our cost problem. If you look at the federal deficit on into the future, it's driven by healthcare costs. It's not driven by anything else. All other things are covered with revenues that are rising at the same rate. Everything else is Social Security included. It's Medicaid, Medicare, and all the other innumerable healthcare programs. That portion of the federal budget, that's what's driving the federal deficit. You cannot have a deficit of $60 trillion. That isn't going to happen. It's impossible. You can't support that. Your nation falls apart before that happens. We solve this, or we don't have what we think we would want for our children. So I don't want to leave you in a place of misery, despair, and gloom. We can't fix this problem. The costs are too high. Where do we go? Isn't it going to cost more to deliver more care to more people and higher quality? Isn't that all going to cost more? Here's a study that was done about a decade ago. This compares the cost of health care to the quality of the care. Every dot on here is a state in the United States. North Carolina is right in the center. Right there. Utah is right up there. Okay. That line is a statistical regression line. It means there's a statistically significant association between the cost of care and the quality of care. Now, most people would think that association is because high quality care will cost more. So naturally, when you have really good care in a state, its costs are going to be high. That would be a positive association between, or a correlation between cost and quality. It turns out it's the other way around. It's an inverse correlation. The states with the better quality are the ones that are up at the top of the graph. And the states with the worst quality are at the bottom of the graph. And the ones with the cheapest care are more towards me. And the ones with the most expensive care are on the other. And you can see that the higher your quality gets, you follow that regression line, the higher your quality gets, the lower your cost is. This is our way out. This is how we're going to make progress and change the way we do healthcare business and actually save ourselves from all those gloomy ends that I just told you about. When you really reform healthcare, and that doesn't mean coverage, okay? There's nothing about this that says coverage. You really reform it and improve what you're delivering. You waste less, you bend that cost curve back down, And people are better off because amenable mortality improves, but it's costing less. And because it's costing less, more people can be covered. It's a natural thing. Does this make sense? Let me explain a little bit more about what waste means. When I'm talking about waste, I'm talking about two kinds of waste in our health system. One is quality waste. These are definitions from my friend Brent James, the Quality Improvement Officer at Intermountain Healthcare. He says, if you want to understand quality waste, you have to think about kind of a manufacturing process, let's say a manufacturing line. Somewhere along that line, he liked to use the example of radios. They're making radios, and they fail to put the tuner in right, so it can't be tuned to the right station. Well, of course, at the end of that line, a radio that can't be tuned is a useless object. And it either has to be, as he says, thrown away or fixed. Either way, it's going to cost you more, and so that's quality waste. That amount extra that you had to pay to fix what went wrong along the assembly line, that's called quality waste. So let me give you an example from healthcare. Nosocomial refers to an infection that occurs in a place of care, like a hospital. We have a post-operative wound infection rate of 2 to 4% in the United States. 2 to 4% of all surgical cases end up with a wound infection in our country. Okay, that sounds like, well, maybe, is that too much? I don't know. He went and looked, Brent James went and looked. That if you did everything right, you followed all the processes that we know how to do, what clinical science says is the right way to handle operative cases from beginning to end so that everything goes ideally for the patient, the actual rate ought to be 0.4%, 1/10 of what it is in the United States. The difference between, at $14,000 per case, the difference between what it ought to be and what it is, that's quality waste. That's because we're not paying attention to what the patient needs. We're not doing what's right, what we know how to do. Somehow we're letting something else get in the way, and it's failing for the patient. And that quality waste is costing us $14,000 per case. Now, that's a little bit of old data there. I'm sure it's more like $24,000 per case today. It's a lot of money, whichever one it is. All right, that's quality waste. The other kind of waste is inefficiency waste, and you heard it already discussed a lot with the business model of the insurance company, how we finance healthcare. But again, if you have, now think of two assembly lines standing side by side. They both have the same inputs, meaning all the materials are the same, the labor that's at the assembly line is trained equally, they're equally skilled, they're as good as each other, right? Two assembly lines, but one of them, it just costs more to run it through. It just not as efficient. People dally more. They waste more time, whatever the reason is, okay? At the end of the day, the difference between the one that uses more resources and the other one is inefficiency waste, because the one is the standard that's best, that's most efficient, shows you that it could be done better. In North America, we have two healthcare systems that are same inputs. MDs and RNs and people who are in other kinds of health professions who pretty much are trained the same. Canada, the United States. Hospitals that very much look alike. You got admitted to a hospital bed in Canada, you wouldn't be confused by it. It would look very much like any hospital bed you've seen in the United States. It's just that at the end of the day, the hospital overhead there versus here is like 3 to 1. Ours is higher. We're inefficient when it comes to actually paying for and delivering the care. The overhead of the American health insurance industry ranges from 15 to 25%. And they're basically in the business of trying to prevent payment of benefits. And so there are providers out there, hospitals and doctors, who are in the business of trying to get paid for delivering benefits. So what do? They mirror image staff up their administrative staff and have huge rooms full of people who are doing billing. And that increases the overhead from 15 to 25% to more like 30%. That's a $400 to $500 billion a year waste in the United States. That's been studied, and that's $400 to $500 billion a year. Now, you can see where we're getting to that $1 trillion of waste, right? We have two kinds of waste. I've just told you that not quite half of it, of that $1 trillion of waste, not quite half of it is inefficiency waste. Why do we do it that way? Why is it that we have devised a system, and it makes it sound like somebody sat down and figured it out and wrote it out and devised it, but of course that's not what happened. It evolved this way. Why did it evolve like this? What is the underlying basic flaw in the way we have thought about healthcare as a nation that is not true of any of the other first world nations? I think you can find it in this quote. I don't know if any of you remember Tony Snow. He was a syndicated columnist in the 90s when he wrote this, and he was writing it because there was a big to-do about the so-called Clinton healthcare plan. And he's a conservative, and so he's trying to advise us about why that was such a bad idea. Later, he became the spokesperson for the George W. Bush White House, the second Bush White House. While he was serving in that capacity, he developed colon cancer and subsequently died before George Bush finished his second term. This is what he said: "In the real world, people stampede when somebody slaps up a sign that reads free. This is the theory behind bargain basements, but it also applies to hip replacements and appendectomies." Okay, first of all, of course, he doesn't quite get what a hip replacement person can and can't do because they don't stampede anywhere, right? Right, so that's pretty obvious. But let me ask you a question. Have you ever known anyone who got an appendectomy because it was on sale? It's ludicrous. This is silly. This is nonsense. This is market speak. This is what we are always told. In fact, we're Americans, right? Shopping is the quintessential American experience. This is how we think. This is why it reverberates in our society when politicians stand up and tell us about, we just need more market forces. That is what they're saying. Because in a market, price determines demand. The higher the price, the lower the demand. And the lower the price, the higher the demand. And they keep thinking about healthcare in exactly those terms. They keep saying people have to have skin in the game. Another ludicrous statement because, of course, when you're at the doctor, your skin's in the game. All right? It's there already. But they keep saying that. Why? Because they keep trying to get us to understand that if we have an insurance product that shields us, which it never does anymore, from the real cost of the care, we'll want more care. That's what they call the moral hazard of the health insurance business model. Well, I've practiced primary care. I've taken care of people as an academic specialist in occupational lung diseases, and I've had a hard time convincing people to just let me do a blood stick because they don't want to get stuck by a needle once, much less get their belly torn open for an appendectomy. People don't seek care. They don't say, give me that, you know what, it's on sale this week, give me that chemotherapy, I'll drink it right now. If I were to offer two $50,000 items up here, one of them's an open heart surgery and the other's a BMW, and all you have to do is promise me that whichever one of those you choose, you go and take it right now. If it's the BMW, get the key and drive it off the lot. And if it's a heart surgery, you go with me to the hospital. We'll open your chest tomorrow morning. I've never yet had a member of the audience choose the heart surgery. Why? Because you're sitting here. You probably don't need open heart surgery tomorrow. If you do happen to need it, though, is there a price you wouldn't pay for it? Or if your child needs it? Price does not determine demand. Epidemiology determines demand in healthcare. The frequency of heart problems that need open heart surgery, that's what determines how many of those we do. And the frequency of appendicitis is what decides how many appendectomies there'll be, not the price. This is not a commodity. And market forces will never fix this. And every time you hear a politician give you a market line, you need to answer back and say, no, that's not how it works. It will never be fixed if we follow that. That is the underlying problem. So how does that play itself out in the health system when this market idea keeps permeating throughout it and keeps focusing our so-called leaders on it? This gentleman, John Goodman, who was part of the National Center for Policy Analysis back at the date of this Wall Street Journal publication, had an explanation for it. It's kind of long and involved. I'm going to kind of capsulize the left half and then read a part of the right half. On the left half, he says, if everybody in the nation could have care like they deliver at the Mayo Clinic or like they deliver at Intermountain Healthcare in Salt Lake City, costs would go way down. He estimates that they would be 25% less in the nation if it were Mayo Clinic-like, and even further down, a third down, if they were Intermountain Healthcare-like. Why? Because higher quality costs less. Remember, I told you that already. Higher quality costs less. Mayo delivers a better quality product, so does Intermountain. He estimated the 25% less would be $500 billion. That makes the third less something like $700 billion per year. There you have the $1 trillion waste. You've got the $700 billion in quality waste and the $400 billion in inefficiency waste. That's the waste that we're losing. Now, quickly add, what I'm calling waste, there's a whole bunch of people out there, they're calling it profit. That's why they keep doing it. And he says that over here on the other side. Not everyone can get treatment at Mayo or Intermountain. Why aren't we following those examples? Why aren't they being replicated everywhere? The answer is that high quality, low cost care is not financially rewarding. Indeed, the opposite is true. Hospitals and doctors can make more money providing inefficient, mediocre care. That is the problem. That's how the market, pretend market, actually ends up causing us these heartaches. It's because they're making profit on the way we do business today. How does this go? In central Utah, and this is one of Dr. James's slide, in central Utah there's a small community hospital in San Pete. San Pete is one of the counties in the middle of the state of Utah. Very rural area, very small community hospital. Mostly on the hospital staff are family doctors. One of the family doctors, a friend of mine, looked around in the mid-90s and said, people with pneumonia in our community are not doing well. They're dying too often, they're too sick. We can do better than this. And he did the research necessary to show how it was that no matter where a pneumonia case stumbles into the healthcare system, it could be treated better. He wrote a guideline about it, and he went around to all of his colleagues on the hospital staff, physicians, and said, will you follow this guideline? And they all said yes. And then he went to the hospital administrator, an Intermountain hospital, a nonprofit hospital, and said, we need the hospital to also follow the guideline. Everybody agreed. Overnight, right at the end of 94 and at the start of 95, they put the guideline in place. And overnight, this is what happened. The percentage of patients with pneumonia that had to be hospitalized, or admitted is what that is, dropped from 39% to 29%. The average length of stay, that's what LOS means, for those who had to be hospitalized, dropped from 6 days to 4 days. They were less sick. And why? Because they figured out how to get the right antibiotic to those patients 1/2 hour sooner. Now, that's a lot of work for a half hour. It doesn't seem like that makes sense, but it made all the difference to these people. The cost per case of pneumonia dropped in half. Boy, market should reward that, right? Boy, this is great stuff. This is what the market did. Here you have the green line, which is the projected or expected cost based on the history of pneumonia care in the community. And of course, it was gradually going up. It's just a straight line going up. The actual cost is the yellow line, up and down. You can see it carefully follows that green expected line because that predates the implementation of the guideline, which is here at this vertical line. That's when the guideline started. People, the actual cost follows the green line all the way up until that moment. And then you see it kind of wavers and then drops. The expected cost drops as people got better at taking care of pneumonia patients. The blue line is what the hospital got paid for that care. The blue line also kind of follows along the green line and then it drops. The problem is it drops more than the yellow line. They got reimbursed less at the hospital than they actually saved in the care of the pneumonia patients. They took a financial hit for helping these patients. That's the perverse incentive of American healthcare. So if you really want to make money as a hospital administrator, let them get sick enough to go to the ICU. Make a few more ICU sales. And then you're going to have a better bottom line. Now, this is a nonprofit hospital. They saw this and they didn't stop. They took this model and they went to all their other hospitals and said, you're going to also do this. But a for-profit hospital ain't going to happen. They would never even let the experiment happen to begin with because they're always looking at profit loss statements. They're never looking at what's really good for the patients. Is this making awful sense? Okay. So perverse incentives cause the waste in our system. Our waste, again, being quality waste and inefficiency waste. There are three major kinds of quality waste, and I'm going to briefly illustrate each of those. And then there's the one that I've already alluded to in the health financing model, the inefficiency waste. Massive variation in practice leads to high rates of inappropriate care. Quality waste number one. I'll explain what that means. 2, unacceptable rates of preventable care-associated patient injury and death. New statistics that Katrina helped me find this week, which are going to, I think, they stunned me. I don't know. I hope you see how stunning they are. Number 3, quality waste. A striking inability to do what we know works. And then 4, the health financing business model that's based on exclusion and denial, that shifts costs, causes uninsurance, and has a high overhead. This is a map that indicates by color the rates of lumbar surgery, a particular kind of back surgery, across the United States. And just for brief, the blue is where the rate is the highest. And the dark green is where the rate is the lowest. And there's about an order of magnitude difference between the highest rate and the lowest rate. This is data out of Dartmouth University. These guys have been doing this on all kinds of surgical and other sorts of clinical interventions for years. They use mostly Medicare data, but I've recently seen data that comes from the younger population under private insurance as well. And what this says is the rate of back surgery is variable, highly variable across, 10 times difference across the country. And they've looked carefully and tried to figure out why it would be that this part of Utah has the highest rate of back surgery while this part of New Mexico has a lower rate. What would be the difference? Are there just people in Utah who need back surgery more often? Is that just the epidemiology? It turns out that none of the good clinical explanations are there. There isn't any reason. People don't have less back problems in New Mexico and more in Utah. This is a business opportunity more than it is anything else. There are some people selling back surgeries at a higher rate in some parts of the country and a lower rate at other parts. We don't even know if these parts, these are dark green, are actually the best rate. Maybe it should be lower than that. Okay? There's a lot of unnecessary care, unnecessary procedures. Estimates of the percentage of procedures, I've got hysterectomy, bypass surgery, angiography, angioplasty, and cataract surgery about that, with questionable being the yellow and inappropriate, totally outright inappropriate surgery being the aquamarine color. We can see that, approaching half of the procedures are wrong. They have no chance in helping those patients get better. One of the stories in my book is about a hysterectomy patient in Salt Lake City. When I was a medical student, I was serving on the gynecology rotation for 6 weeks it was an Intermountain Healthcare hospital in Salt Lake City. And my job as a medical student was to meet the patient when he or she, and in a gynecology rotation, it's a she, as she came into the hospital, and do her admitting physical examination, put that in the chart with the history, get the various labs, everything prepared so that the next day when she would go to surgery, everything be ready. And I was on a general surgery rotation. I had just been on a gynecology rotation. So I knew what the indications were for gynecologic surgery, like hysterectomy. I knew that in this particular case, there was no indication. She was 30 years old. She'd had pelvic pain for a couple of weeks. It was vague, nonspecific, and there had not been any clinical investigation into what might be causing that pain. Most of the time, when you have a 30-year-old with pelvic pain that's 2 weeks in duration, you're going to wait for a while and just see what happens while you do maybe a few carefully selected studies. This general surgeon admitted her to the hospital the afternoon he saw her and said, what we need to do is take the uterus out. Not only that, we have to take both of the ovaries. Okay, I saw this patient in the afternoon before her surgery, and I said to myself, this is wrong. This is wrong. She's 30. She shouldn't be put into surgical menopause, even if there's a reason to do the hysterectomy, and I don't see one. So I went to the attending surgeon and told him that after I'd gone to the library and printed out a variety of articles that showed that ovaries left behind after hysterectomy do not cause cancer or do not become cancerous at a higher rate. Ovarian cancer is not more common in hysterectomy patients than in non-hysterectomy patients. That's the better way to say it. And he was furious that I would intervene like that. And he told me that he could find articles that said exactly the opposite, which of course he never found. And I said, look, I'm not comfortable with this. I'm going to withdraw from the case. I'll go do somebody else's workup. And he said, you withdraw from this case, I'm going to make sure you flunk out of medical school. So there I was the next day when we operated on this poor woman. He didn't have a clue about the anatomy of the pelvis. He had no idea. He's a general surgeon. He did appendectomies. He butchered the case. She lost 5 units of blood before the organ was removed. Had it not been for the case that the chief surgical resident was in the room and he had great hands and great instincts, and he saved her life, she would have died on the table. She would have been one of those accidents that I'm about to talk about. She survived. The story's in the book, and it's there to remind you, to the reader, we have high rates of inappropriate care in this country. Care that's not only not at all going to help the patient, but it's likely to hurt them. Okay, number 2, care-associated injury and death. Medical errors cost $20 billion a year. I'm sure that's an underestimate, but that's what we have in the published literature from the National Institute of Health. Quote, the true number of premature deaths associated with preventable harm to patients was estimated at more than 400,000 per year. How many deaths do we have due to cancer in this country? Anybody know? 600,000. That's the number 2 cause of death in this country. Number 1 is heart disease and stroke. How many deaths do we have from that? Again, it's about 600,000. 400,000? 400,000? I used to, this is a new slide because Katrina forced me to get a new slide. My other one was outdated, and I used to, using the data from that other slide, I used to say, if a fully loaded 747 crashed and burned every other week, that would represent on the airline industry the real risk for patient loss that the hospital industry has. It's actually a lot more than that. People were aghast every other week. Wow, that's terrible. No, it's more like more than once a day. That's what's happening. This is what we should be afraid of. You know, people often try to get you to be afraid of change in the health system. They say, oh, socialized medicine, that'd be terrible. Try to get you afraid of that. Or death panels, another one of those fear-mongering things that they say. You want fear-mongering? This is what you ought to be afraid of. I've said this to my family for years now. Do not go to the hospital without somebody with you. Do not be in the hospital without someone with you. When I need to go in the hospital, Caitlin goes with me. Caitlin is there. Why? Because we have been distracted so much by the business model and the for-profit model of American healthcare. We're not attending to the basics. This is why the maternal mortality rate is rising in our country and not falling. It's not because of some terrible thing. American women are presenting high-risk cases. No, it's simple stuff. They're not actually carefully monitoring ins and outs at the bedside. They don't know how much blood loss has really occurred. They're not following it. They're not doing the basic things that I was taught to do 30 years ago. And every nurse knew how to do when I was on a labor and delivery unit when I was training. It's not happening anymore. So women are dying of things that they don't need to be dying from. That's it. Doing well what works. We have a healthcare system that's so distracted by its business model that half of the time is all we get to do the right thing for the patient. Clinical science tells us a bunch of things ought to be done, just automatically. Like someone shows up with chest pain and it might be a heart attack, it ought to be an aspirin in the ER right on the spot. Half the time that happens. And I don't care which part of the healthcare system we're talking about. ICU, ER, surgical unit, I don't care where you are. Operating room, it doesn't matter. Half the time, that's what this study said, half the time we do the right thing for the patients. That's quality waste because we're letting an opportunity go by to save that patient from future problems. And when we break it, we either have to fix it or we let them go. And 400,000 times a year, apparently we let them go. So if we're going to really reform healthcare in the United States, we can't do it by just saying we're going to come up with more tax money, even though we're already taxed more heavily for healthcare than any other nation is. Did you know that as a fact? $10,000 per person is the healthcare cost. 2/3 of that is tax money. 2/3. That's higher than any taxation rate for any other country. Socialized medicine costs half as much as that. All right? We're already taxed more. What do they say? What did they say for Obamacare? Let's raise more taxes and pay more for more coverage. That's not health reform. This is health reform. I've got here, UHI stands for the Utah Healthcare Initiative. That's what I called my effort in Utah. I am about to tell you about a state plan for health system reform. A national plan would be National Medicare for All, which would be great. And I fully support it. But I'm going to tell you something about a state-based plan, because if I say Medicare for All in Utah, I'd get tarred and feathered and thrown out of the state, all right? You're lucky here. You get to even talk about it. Medicare for All is one option for single-payer reform. Single-payer means one payer for an entire region. Medicare for All would be one payer for the entire nation. I'm talking about one payer for each state, which actually would be equally efficient. And I'll show you how I propose to go about doing that in the next slide. But here is what I try to explain to people, is how you attack the sources of waste with proposed solutions. First of all, inappropriate care due to the massive variation in practice. And I use as an example defensive medicine, because that's a favorite from the right side of the aisle. Oh, we can't have that defensive medicine. What is defensive medicine? Well, obviously it's medicine, but not for the patient. It's for a different reason. It's to protect from legal problems. The doctor's worried that he might get sued. And it's therefore inappropriate care, right? It's not care delivered that's necessary for the patient's need. All right, so massive variation in practice requires that everybody get the same benefit, but not more than that benefit. So you define the benefit by what works, what the clinical science says works, and what's the least expensive alternative. And I propose that there be a commission set up specifically to identify that. I don't think it'd be as hard as it sounds. Most doctors can agree what works and what doesn't. And most doctors can look at that hysterectomy case that I told you about and know in advance that's not appropriate. That's not where we're going to spend our money. There are a variety of other examples I can give you, but let's move on just to shorten the time. Unacceptable rates of preventable care, associated injury, and death. How do you prevent that? Well, that's a public health problem. Individual patients can't do anything about that. They don't know when they're being injured or when they're being set up to be injured. They go to sleep and they wake up and find that the wrong side of them was operated on. I mean, there's nothing they can do about that. What we can do about it is have a public health agency identify what is a preventable injury and standardize that and mandate that that must be reported to the public health agency. In Utah right now, death that is caused by preventable injury is reportable, but is at passive surveillance, meaning it's at the decision of the provider. If they want to report it, they can. And even though it's that, a death a week is reported. That's just the tip of the iceberg. Okay, if we mandate it, we'll actually find out what's going on. Why do these things happen and what can we do about them? You can, with public health, you mandate a case report, say, for tuberculosis. Why? Because you want to not only know about the case that already has been diagnosed, but you got to find out who's been exposed to it. And the exposure in this case is not contagion. It's a system that's failing the patients. That's what they're being exposed to. You find out what the exposure is, and you do something about it. Once the hospitals know that it's mandatory and that it will be in a public agency's files, I'll bet you money they'll clean that act up pretty darn fast. It'll happen. All right, that's how you deal with injury. The striking inability to do what we know works and the health financing business model both have to do with how we actually deliver the care and finance it or pay for it. I propose creating a single payer in Utah, take the public employees health plan, the most efficient payer in the state already acting, and give them everybody as a beneficiary in the state of Utah. Single payer for all of Utah. All of the money destined for Utah's healthcare system, which I estimate to be something less than $20 billion, combined from the federal sources, the state sources, and also private out-of-pocket, all of it will be given to the Utah Health Cooperative. And they will be in charge of organizing better ratios of primary to specialty care, public financing that actually reduces the overhead. We'll save $1 billion just off the top, really quickly, just by lowering how much overhead is reducing the amount of overhead. We'll provide claims management that's efficient, and then we'll look at the things that are currently often on the margins and not well cared for. Chronic disease management, behavioral health issues, and the quality improvement that was pioneered by the hospital system in Utah, that every hospital in Utah ought to be using, that improved the care, for instance, for the pneumonia patients. That's my proposal in brief. A new commission to decide what the benefit is, a new reporting system for patient injury, and a new payer that's in charge of all the money for all of the patients. Okay, how can we make that happen? Well, it's not any different from how we can make national Medicare for all happen. You have to change who's in Congress. States cannot do this right now because there are federal rules and regulations, including things from Obamacare, but many things from many years preceding that would keep Utah from doing that. We have to change the law of the United States of America in order to allow a state or the nation to have a single payer. So this group here is working on trying to get candidates for Congress to say, yes, I'll sign on to Medicare for all. In Utah, I'm trying to get congressional candidates to sign on to, yes, I will support the legislation for state-based universal health care. It's called actually the State-Based Universal Health Care Act, and it's already been introduced by the same person, by the way, who is leading the National Medicare for All coalition, Representative Jayapal from Washington State. She's got both bills. She's doing them both. Why? Well, National Medicare for All may take longer than we hope for. Politically, it's going to be a heavy lift and difficult. Relatively few people from the right side of the aisle are going to cross over and support it. I'd hate to see us in the same Obamacare mess where as soon as the Congress changed hands, they would start trying to destroy that change. I have heard many Republicans say to me they would support state-based universal health care. So politically, I'd argue it may be a faster way for a single payer, and then we'd have to fight it out state by state. The other thing is there are certain things about state-based innovation that are significant functionally for how the health system works. For instance, Utah is a vast frontier for 75% of its land area, meaning very small population, tiny population, and huge areas. Doing trauma care, and that covers the 5 great national parks in Utah, which many, many people flock to and go visit during particularly the summer months. That's when the trauma occurs. We need a system that will meet that demand and teach those small town hospitals and doctors how to do the golden hour care that they need to get those patients to the right place. That's a different challenge than you have in North Carolina. And I don't pretend to know what your biggest challenge would be here. But states have to be able to function at some level in the control of the delivery of care in order to make this work. The book talks more about this in some detail. So state-based innovation and control, a federal minimum standard in funding, you have to reduce the waste. If you don't have a reform proposal that's actually attacking the waste, you're wasting your time. It's not going to change anything. And then it's got to be that we control instead of the private corporations control. And I'm still arguing for private healthcare delivery. I don't believe that we'll ever see a socialized system where the hospitals are owned and operated by the government and doctors and nurses are salaried. So I've placed the public or the community control in the hands of these two in Utah as the proposal. That's the details about the State-Based Universal Health Care Act. It's HR 6097. Jayapal introduced it, and she has 7, I think, co-sponsors, mostly from the Pacific Northwest. They're all Democrats. I'm making it my business to try to get at least 1 R on that list by sometime next year. And I do have a book for sale in the back. I'm asking $15 for it, and $5 of that price will go to this organization as a donation from me. I'll be happy to take questions. Thank you very much.
Before we take questions, I just wanted to make one quick correction. What we are proposing is not socialized medicine in the way that Dr. Jarvis was talking about, that the hospitals and the doctors would be employees of the government. HR 676 is a publicly financed but still privately delivered healthcare. I just wanted to make that little correction. Anyway, we have a microphone so that we can hear everyone's question. It's right behind Katrina over there. So if anyone has any questions, please go to the microphone. I know it's hard to be the first one, but there's got to be questions. Okay, great.
Yes, I should have made that clear, that Medicare for all, Medicare is, of course, not a socialized medicine system. Medicare is a government payer with private healthcare delivery, and Medicare for all would be the same. That's absolutely right.
In the Utah bill, what would the people, the citizens of the state who had Medicare, would they still use Medicare, or would they all go under the state plan run by Utah?
They would all go under the state plan, and that's why I said it has to be federal minimum standard, because as a minimum, what's delivered to Medicare beneficiaries must be delivered to everybody, because they can't lose. Medicare beneficiaries by law have to have the same. That, in fact, is clearly stated in Jayapal's bill. You can negotiate, the state can negotiate with the federal government for all of the funding and release from all of the various rules and regulations, but the Medicare population should see no loss, but in fact an improvement in their benefit.
How does your plan address pharmaceutical costs, drug costs?
Medication costs are included as a benefit, and we would have the benefit committee, the thing that I'm proposing, the government agency would decide what's on the formulary, and then the state, using its monopsony power in the state, would negotiate a best price.
So you would have direct negotiation.
Absolutely.
Which, of course, would be one of the things that would change if we had national Medicare for all, is the ability to negotiate drug prices. So that's part of what's built into the state proposal.
Well, I would hope that we would have that nationally if Medicare for all is passed. But remember, they passed the Medicare drug benefit without
Right.
that ability.
Yeah.
In fact, the irony of this is the one that there were two plans, one with negotiating power and one without, right? And the one without negotiating power won by one vote. And that one vote was the Democrat, the only Democrat from Utah in the House, who switched sides and voted for that ridiculous idea that we shouldn't negotiate. Or we're going to basically say to the pharmaceutical industry, we're going to buy all your medications. How much do you want to charge us for them?
Right. And then would you also, as part of your, I mean, it sounds like part of the quality control that you would be introducing would be, I'll use the word mandating, but you would be requiring evidence-based care.
Yeah, the way this works, the quality improvement that I started to discuss, that Dr. James was so good at implementing at Intermountain Healthcare. I'll give you an example from maternal cases. I sat through a number of lectures that he delivered, and one time he talked about discovering that there was a very high rate of C-sections, in his opinion, and I think that's true nationwide. And because of that, there were lots of babies who were ill and had to be cared for in the newborn intensive care unit, and he had a number of members of his medical community in neonatal and perinatal care look at those data, and they ended up deciding that a significant problem was the elective induction of labor that was occurring in all of the Intermountain hospitals. So they started carefully studying that, and just like the pneumonia case, they ended up deciding that a big problem was doctors were, often with the consent and active involvement of the mother, were deciding to induce labor when there was no clinical indication for it. There's a great thing called the Bishop score, which determines when a woman's really ready for an induction of labor. And they set as a standard, there will not be labor induction unless the following clinical criteria are met. And they dropped their rate of C-sections, and they dropped the newborn intensive care. This all came up from the ranks. Those doctors and nurses participated in setting the standard and then policing it. Now, there were some doctors who didn't like being told how to practice medicine, and they left and went to some other hospitals. But Intermountain maintained that standard. That's what I envision to be quality improvement. It's going to come up from the ranks. The people who are at the bedside will know what needs to be done.
Thank you.
I know a little bit about Utah, and Intermountain is so dominant there. What do you have, 23, 25 hospitals, all part of Intermountain?
That's correct.
It seems to me, and you've got, as I said, a great advantage. You're not as big a state as many states, and you have much more buy-in from your participation. The Church of Latter-day Saints is very powerful in the state, and so I'm sure when it comes to the legislature passing laws, ideally, the insurance companies like United and Altius and Blue Cross, and how do you get them on board? You're basically putting them out of business. Is that true?
Yeah, a single-payer system would put United and Blue Cross, et cetera, out of business. That's absolutely the case. It would also put the Intermountain health plans out of business. They're called Select Care now.
Okay.
So they would be out of business. And Intermountain hasn't necessarily liked what I've had to say.
Sure, yeah. I know Utah a little bit. I was a vendor to the Utah Health Information Network 20 years ago.
Okay.
So we spent a lot of time in Utah. The hospitals also in most states would have a much more powerful lobby to fight this. And again, that's why I brought up the power of Intermountain being so dominant. A state like North Carolina, I can see a much longer time frame to get this accepted. And back to your state, how soon, what if everything went your way, how soon do you see this actually being implemented?
Well, the passage of the State-Based Universal Health Care Act is the first step. There's no point in arguing about this at the state level until that bill has passed, because there isn't any way forward. All of the single-payer, so-called state-based single-payer legislation or voter initiatives, ballot initiatives that have happened to date never could have actually come to fruition because of these federal barriers. So that's the first step. Now, how long will that take to pass? That's actually the more critical question. I've just made you the argument that I think it'll pass sooner than Medicare for All. But I don't know. Medicare for All is easier to say. It's simpler to understand. There's a growing, swelling sort of feeling for it, although exactly what it means, I think a lot of people don't understand and could easily be dissuaded. I would tell you that I don't believe the elite leadership of the Democratic Party is on board with it. I think they are fighting it tooth and nail. And now they've learned to be very cautious and careful in how they oppose it, and they are reframing it. And I think we'll be surprised that if, in fact, there is a Democrat majority soon in Congress, that the legislation they'll come up with won't look at all like Medicare for All. And they'll call it that. But just like they called the Patient Protection and Affordable Care Act something that's totally not true. All right, so that's the answer to the first question. Now, the second half of that is at the state level, how fast can I see it happening in Utah? Actually, that'll be an agony. Intermountain Healthcare has recently changed management, and it's acting more and more like a for-profit entity, trying to expand into other states and doing all of the things that you're used to seeing. I mean, dumbing down the bedside care and reducing patient ratios, et cetera. I'm very fearful that the era of Brent James is over. He no longer works for them. This new management didn't want to hear from him anymore. So I don't know that they're actually going to be someone that I had an uneasy friendship with the previous leadership and eventually began to get somewhere with them. But they were hotly contested at the legislature, that is Intermountain Healthcare, because the other players in the state are for-profit. The other hospitals, and there are two major other systems, are for-profit, and they were able to, using their for-profit high amounts of money to lobby, they were able to persuade the legislature often that Intermountain Healthcare was an enemy of the people. It was very difficult. I actually had to go to the legislature and testify not about single payer or the things that I really cared about, but by saying being a nonprofit is actually a good thing. I had to go and try to pull the bacon out of the fire for Intermountain on a couple of occasions because of this. So I don't know how fast that can turn around. Now, on the other hand, we need to remember, as a group of people who cares about single-payer reform, we need to remember this is not a static but a dynamic situation. We're sliding into second-class status as a nation. Our health system is crumbling and more people are dying. more and more people are going, this is happening more and more rapidly. That can change things very quickly. A political moment can happen like that, and boom, it's going to change. We'll have and even the very people who were against us before will turn around and vote for us. This can change quickly. But we have to be ready to accept that moment. We have to be ready to use that moment when it happens. I intend to try to be ready in Utah. I think North Carolina is more likely to pass the law that I'm after than Utah is.
We haven't expanded Medicaid either.
Okay.
I don't know about that.
Okay.
Hey, thank you for being here. So as a med tech, I know that there are regulations around quality, and I want to talk to your point about quality because
Okay.
I think that's really important. So there's regulations around quality with the diagnostic side of things, with JCO and CLIA and CAP. Are there not regulations around treatment also?
Yeah, not nearly in the way that you mean them. Not at all like the way you mean them. And even those, the ones that you've described, are not as adequate as we would wish that they were. I'll give you an example. The robot, Da Vinci robot, was introduced as an adjunct to surgery, just a few years ago. This is a medical device, and surgeons use it to operate remotely from the patient. Now, they're not in some other hospital, they're in the same room, and they're looking at a scope or a screen or something. I'm not a surgeon, so I actually haven't seen this, but they're manipulating things with their hands, and those things are then translating into motions at the site of the wound. You would think that this is something that we really know a lot about and we would carefully control. Turns out not. Turns out it's a medical device and there's absolutely no control over it. Doctors who had a couple hours of training were actually using it on patients. And then the wounds that they had stitched up after the surgery would dehiss, meaning totally fall apart a few weeks later, because it was totally not regulated. If they had sat there, stood at the side in the traditional way and done the sewing by hand themselves, it never would have fallen apart. But the fact they were using this remote robot let it happen over and over and over again, like hundreds of cases occurred like this. Is there any place for those patients to go and report that? No. I mean, some of these patients had vaginal hysterectomies done and the wound dehissed and their intestines fell out onto the floor at home. There's no place to report that or for anyone to even accept that that actually was a complication of the use of this device. That's the state that we're in with surgery in the United States.
So was part of your proposal to have a regulatory body that will address those kinds of things?
That would be a
improve
reportable event. That would be a mandated reportable event that would go to the public health department with the money and the charge to do something about it. Yeah, absolutely. We should have, actually, a Food and Drug Administration that better manages medical devices. They do a poor job at the pharmaceuticals. They do almost next to nothing about the devices.
Hi. You've very clearly made the point that the problem is not so much coverage as it is cost. And you've demonstrated how some places like Mayo Clinic and the Intermountain Health are able to provide high quality at lower cost. But that's not true, unfortunately, throughout most of our country. And so how then do you incent providers to provide quality care knowing that they're going to make less money doing that because they're going to have healthier patients, they won't be keeping people in the hospital as long, they'll be doing fewer procedures, so they make less money? What's the incentive for the medical providers for doing that?
Well, you've made my point. You've made my point that the profit motive is what's driving behavior in our system today. And I'll make the point back to you that a large number of doctors and nurses are not happy about it. In the book, I talk about the discovery of the drug penicillin, which occurred almost 100 years ago now. It was a serendipitous discovery by a doctor who was trying to do bacteriology in his lab across the street from a pub in London, and a colony of mold invaded his plate, his bacteriology plate, and killed off a bunch of bacteria. And he realized that was an important discovery. Now, he didn't end up figuring out how to mass produce penicillin, and it took another decade for that to happen, which happened, by the way, by government spending, not by private investment. That doctor never thought of himself as someone who should be cashing in on that, really. That's probably the discovery of the last 1,000 years. He never thought of himself as someone who should be financially enriched by that. And most doctors, over the course of the history of medicine, would fall into that category. Yeah, they should be paid well. They expect to be paid well. Higher levels of income. It's a hard job. It's hard training. But most of them didn't go into it solely because they thought they were going to be made wealthy. In fact, if that's what they were really about, if a young person was really about that, they'd go to law school or get a CPA or something. I don't know. I didn't do that, obviously. In fact, this is another story from the book from my family. Caitlin's older brother, who, when he was 4, was asked by somebody, "What do your parents do?" My wife is an attorney. She's a corporate bankruptcy attorney. And his answer was, "My mom is a lawyer. She works for money. My dad is a doctor. He takes care of sick people." That's a distinction I think almost everybody understands. Altruism is a bigger motivation than people in the market economy give it credit for. And that is what I'm depending on. I'm basically saying if you give doctors and nurses a chance, they will do the right thing. Most of them will do the right thing. And the ones that don't want to do the right thing, they just want to make money, well, we need to drive them out of this business anyway.
Could the cost of medical school be driving
Yes.
that bad behavior in any way?
Yes, I agree that that's the case. I graduated with $100,000 in debt, and that certainly drove behavior, although I still chose to be a public health doctor, which I guarantee you doesn't make a lot of money. But yes, it's true, and we need to do something about it. I believe doctors need to, and nurses too, need to recognize they have their skills because there's been a bunch of patients who have taught them, given them a chance. The first time I drew blood from a patient, I didn't know what I was doing. That poor guy, I must have stuck him 6 times. But he was patient and he let me learn, and I owe him. I owe him big time. I think in exchange for, the doctors ought to recognize that they are getting a gift when they go through their training. Nurses too, and other health professionals. And yes, part of that gift ought to be, the cost ought to be manageable. So that afterwards, they're more interested in and taking care of people and doing the right thing, and all of the various things that we consider medical ethics.
All right, thank you.
Mm-hmm.
I guess I'm wondering what suggestions you have for us in how we fight the bribery which the health insurance companies and pharmaceutical companies use to win votes.
Oh, yeah. The medical industrial complex is the biggest, bar none, donor of money to the political process in the United States. In fact, I think I've seen some statistics that indicates that you can add up virtually all the other complexes that are out there in terms of business interests, and they don't spend as much as the medical industrial complex does on political donations, lobbying, which is a separate issue. Yeah, and I discussed that a little bit in the book as well. But you know what? It still comes down to votes. And you still can get people alarmed about what we've talked about tonight, and get them persuaded that they have to hold people accountable. If they're going to be representing us in office, we're going to insist that they introduce and carry legislation. And if they don't, we need to vote them out. I don't care how much money is spent on their campaign, we vote for the other guy. And you need to stop being red or blue. I used to be a Republican. I'm now unaffiliated. But I will vote for whoever is on my ballot who will vote for the things that I know will work in healthcare. And I'm trying to persuade everybody I can in Utah to do the same. Vote for the person who's going to, and if they go there and do it, great, vote for them again. If they go there and 2 years later you've noticed they haven't done it, kick them out. I guarantee you, if you do that once, you will change the face of politics, healthcare politics. I don't care how much money is spent.